Hi, Viva Lifers. This is Dr. Kelly, O.M.D. I am the CEO of KOE Medical Consulting, and this is Ask Dr. Kelly, O.M.D. It is a program that we host for the Viva Life Health Hub. The Viva Life Health Hub, the goals are to help you live your healthiest and wealthiest life spiritually, physically, financially, mentally, and emotionally. We have several packages that are available to you so that you can do this. One of the offerings that we have is called Ask Dr. Kelly O.M.D., and that is why we have the world-renowned Bill McDade. So Dr. McDade has been my mentor, advocate, and sponsor for the last 20 plus years. He was one of the first people that I met when I was on my journey going into medical school. He took me under his wing and so many other people, and then he made sure that I have been successful in my entire career. He not only has done this for me, has done this for hundreds, if not thousands, for others. Dr. McDade, tell us a little bit about yourself and kind of the top 3 things you want people to know about being and closing the gap in healthcare disparities.
I would say that I am a South Side of Chicago native. I grew up on the South Side. I ended up going to college as a chemistry major, and then I went to the University of Chicago when I started medical school, and I was in a program that focused on both research and clinical care. It was called the Medical Science Training Program, where I earned both an MD and a PhD. I have a PhD in biophysics and theoretical biology, where I studied sickle cell disease and ran a laboratory for many years, and I'm clinically an anesthesiologist. I became involved in medical administration very early in my career, almost too early to be successful as a scientist, I think, and I became an administrator. I was an associate dean at the University of Chicago for many years, and then I was actually asked to be deputy provost for the entire university. I did that for 2 terms and then went on to become chief academic officer for the Ochsner Health System down in New Orleans. So I ran a medical school there, the residency programs, and the research that goes on there. And then I returned back to Chicago because my mission at Ochsner at the time when I left was to build another medical school, and this one in concert with Xavier University of Louisiana, a school that Dr. Kelly O knows very well. So that deal got quashed by the governor for a time, and so when the door closed there, I decided I'd come back to Chicago and pursue the work that we do at ACGME. The Accreditation Council for Graduate Medical Education is the nation's accreditor of physician residencies and most fellowships. If you want to become a physician in the United States, you have to get a license in any state that you're in, and any state that you're in requires that you train in an ACGME accredited program. So from this perspective, I touch every physician in the United States who trains here. And that's a really important vantage point, which is what it made it more important, I think, to do this work as opposed to stay down at a single institution. The ACGME is a group that is responsible for looking at the quality of residency training environments and residency training in general. And one of the goals of that we have, the principal goal we have, is to improve individual health as well as population health. And that's our focus, and we do it through accreditation and education. And the idea that we can actually change the way that every physician thinks about or does something is something that we can control through our requirements. We require every residency program to follow those requirements that are established by specialists in each specialty in medicine. So it's a really complicated process, and we have a set of rules that are called the common program requirements that every program has to fulfill. And there's specialty requirements that only specialties can say what those additional ones are. And then finally, there's institutional requirements where there's institutions that actually house the residency program that then have a set of rules, and they're all governed by ACGME. So we have a chance to try to influence medicine in the right way. One of the ways that we've been doing it for the last 12 years now is by what's called the Clinical Learning and Evaluation Review, or the CLEAR program. And in it, we ask every resident in every program to engage in a process of learning about health disparities. That is, the differences between health of a population of one type versus another type. For our health disparities, we're talking about racial and ethnic health disparities. So this is the likelihood, for instance, that an African American will live as long as a white American, or the likelihood that African American will suffer from heart disease more frequently than a white American, or that a Latinx individual will suffer from diabetes, or an indigenous individual will suffer from rheumatism. I mean, there's all these things that we can actually assess differences between healthcare outcomes. And so one of the ways that we'd like to do this and is to see who cares for whom, because we understand that there's a fair amount of racial concordance that occurs with respect to who cares for whom in society in America. And this comes because of all kinds of reasons. I mean, first of all, we think about America, you think that we actually live in a fairly segregated world. These racially segregated communities where disease burden and health inequities are strongly concentrated are focused on those areas that have the largest concentration of marginalized individuals. We also know that people tend to seek medical care within their own communities and don't leave their communities for a multiplicity of reasons. We know that historically marginalized practitioners tend to practice in these underserved communities and serve the same residents. And we know that the odds are high that a Black, Latinx, or Asian American physician will disproportionately see a patient of their same race and ethnicity. And then I could show you data, but I'm not going to today, from the ACGME that looks at the number of people, the percentage of people we train as a function of race over the last 20 years now. But what I can tell you is that in 2004, 2005, the year that residency class started, the African-American percentage of residents was 4.9%. If we follow it through to 2018-19, it was still 4.9%. And if we look at today, it's 5.1%. And if we average back over the last 10 years, it's 4.8%. So we're not gaining any ground at all. And what we've noticed is that there's some headwinds that are now facing us that society is imposing on trying to get more minoritized people into college. And those minoritized people will eventually be the people who go to medical school. And when they can't get into medical school or don't go to medical school, there's going to be fewer people to select for residency programs in the subsequent years. So there are problems that are facing us, so that teaching diversity, equity, inclusion in medical schools and colleges and institutions, requiring people to try to improve their environments by learning about implicit bias and learning about how they can improve their environments. There are laws that have been instated to stop this. There are laws that have been instated to dismantle diversity, equity, inclusion offices. And so it's so important for us to key in and keep the momentum going that was generated back in the time of the unfortunate murder of George Floyd and Ahmaud Arbery and all the rest of the individuals that we can cite by name over the last several years. You know, there was a lot of lip service paid by many institutions, many states even, and now they're backtracking. And so we have to keep their feet to the fire. We have to keep them committed on the goal of trying to increase diversity. In the healthcare professions, one of the interesting things that came out of the Supreme Court ruling was that we have to have metrics in order to assess how long we'll need to have affirmative action. Well, I think the metric in healthcare should be how long we have health disparities. If we have health inequity, then we still need to have a diverse workforce, because that's the prime metric. That's the prime mission of creating a diverse workforce. And mind you, that's not my idea. That this racial concordance thing, Black physicians taking care of Black patients disproportionately, that wasn't my idea. That goes back to the foundations of how medical education was structured back in 1910, when Abraham Flexner wrote the famous Flexner Report, which really deals with how medical education was going to be executed in the United States over the next 100+ years. Back in 1910, there was a special chapter, chapter 14 rather, in the Flexner Report on the medical education of the Negro. And in that chapter, what Flexner writes is that we have to keep at least a few, not too many, but a few medical schools open to serve African Americans, serve Blacks. Actually, the Negro is what he wrote. One of the reasons we have to do this is because at the time there were 60 million whites and 10 million Blacks. And those 10 million Blacks in this country could represent contagious spread of disease to the white population without physicians. And white physicians weren't expected to take care of Black physicians back then. And so they have to have a number of the best of their race to care for their population. That was the definition of racial concordance. That was the reason why Meharry and Howard universities were kept open when all the other medical schools were closed. There were 14 historically Black medical schools before the Flexner Report. There were 7 at the time of the Flexner Report. All but those 2, Howard and Meharry, closed after the Flexner Report. When I was a first-year medical student, 50% of all Black physicians graduated from either Howard or Meharry. And I will tell you that the oversized representation that the historically Black colleges, and there's 5 of them now, or actually there's 6 online, two online, 4 in existence now. One just became a medical school this year, and that's Charles E. Drew Medical School out in California, became its own 4-year medical school. They still represent an outsized role in training African-American physicians in this country and African-American residents, in particular at Howard and Meharry and Morehouse. So that's the importance of having this racially concordant workforce in order to try to drive health equity. And health equity is an important element of limiting health disparities, because if you don't have people to care for you, you won't have people who can help you to eliminate your disease.
So as you were saying, you talked about a clear program. So it's a clear review from what I can understand. And I've been a part of 3 organizations that have had the clear review. And it's really interesting. You come in and ask a lot of questions of the residents, the staff. But one of the things I recognize is that you are trying to make sure that the residents are putting forth their healthcare disparities reduction plan. Can you just tell us maybe 1 or 2 of the best ones that you've seen, not only on paper, but actually enacted in the organization?
Well, I think some of the best work that's done in elimination of health disparities really deals with having the data in your hands that you can look at. Many physicians complain that the electronic health record is inadequate because you put data in as the physician, but you can't get the data back in many situations. And there's separate instances or installations of Epic that, for instance, is one type of system that exists where you can actually now start to get into the data with a process they call Slice or Dicer. And then there's another one that's called Reporting Workbench that's right in Epic that you can use to start teasing out your information. I think every resident should learn how to use those particular tools so they can look at who they see and whether or not there are disparities, whether there are differences in the care outcomes of patients as a function of race and ethnicity. The better the tool that you have to assess your own data, the more you're going to have an ability to impact the care that you provide, because now you can start to identify patterns. And when you see patterns that you can identify, maybe it'll start to occur to you that maybe I'm doing something different with these people than with those people. And if you're doing something that works, then maybe you can show what that is to your colleague next to you who's still having those disparities in their care. And that's the beautiful thing about having a diverse workforce, because not only do you as the minoritized person bring something of value to the experience that you have with patients, your non-minoritized individual colleagues around you can observe you, or you can potentially let them see what you do so that they can start doing the same thing. And language concordance, another important element of what we do in medicine. You know, if you see somebody using a family member as an interpreter for a patient, you can step in and say, that's probably not the most effective way of interacting with that person to get the best information from them, and then help them understand potentially why you want to use a trained medical interpreter as opposed to having a family member contribute in that way. So those are the sorts of things that I think can help you assess what you're doing in terms of your success in eliminating health disparities. You got to count, and you've got to look at your numbers. The other thing I think you have to do is to try to figure out what that person is experiencing beyond what you see in the exam room. That is, that if you don't know how that person lives, it's very hard for you to try to keep that person healthy. If you don't think that they have, or if they don't tell you that they don't have a safe place to exercise, if they don't have sufficient food, if they don't have the ability to stay warm in the winter, then you don't know if they're just sitting in your office, because they may not share all that information with you. So sometimes you have to dig deeper and look into what we now refer to as the structural determinants of health, social determinants of health. For many years, people in medicine thought, well, that's kind of a touchy-feely sort of thing. But now there's actual compensation that you're being paid to investigate it by the insurers because they recognize how it improves health. And so when you get paid for something, people see value in it somehow. And now it becomes an important thing to ask. And there are these new modifiers that have been introduced to try to help you identify the social determinants of health so that you can deliver better care to patients. I think this will eliminate health disparities or move to the elimination of health disparities more rapidly than almost anything else. I mean, the physician-patient interaction is important, but it is also those social determinants of health that determine how healthy that person's going to be.
So here's a question. There doesn't seem to be a clear answer to the question, but like most things that are historically Black, there's so many other cultures who are now attending these Black schools. It appears that by them being there, they are taking the place of other Black students who need to be trained to take care of our Blacks. How do we continue to make sure that Black students are admitted to these programs and not be left out?
Well, that's a great question, Tiffany. The Supreme Court has tried to lock the door on that to a large extent, because if you eliminate the ability to ask about the race or ethnicity of an applicant, you might find that a number of non-Black people apply to historically Black colleges and medical schools. And one of the things that you're concerned is, can you admit somebody to a Black medical school who's Black if you don't know their race, based on them telling you what it is by a racial designator? But fortunately, Justice Roberts left a door open for that, where in your statement, if you suggest how race has influenced you and influenced your life, that may now be put into an application, and people might actually use that to say, oh, here's somebody who understands the experience of an African American from a firsthand perspective. These are the sorts of people who are consistent with our mission to educate, and we will select those from that group of people. I suspect that medical schools and residency programs, medical schools and colleges will use this sort of an approach, because that window was left open in the Supreme Court decision to try to keep historically Black colleges and medical schools Black to a large extent. However, I had a recent conversation with a trustee of a historically Black college who said, we're just not graduating enough African Americans to fill our colleges. And what happens is you have to admit other people in order to keep the lights on at the place, at the institution. And so we're not finding that we're having to turn people away at historically Black colleges, some of them, that in fact, what happens is we don't have enough applicants. And so they're admitting people who are not minoritized. When I listened to what the former president at Howard said about Howard, he said Howard is one of the most diverse campuses in the country, meaning that they have taken on people who are not just African American at Howard. And there's a responsibility, I imagine, that we have to help educate everyone, but that schools have to help educate everyone, and to provide insights to the people who are going to be leaders in the future, both minoritized and non-minoritized. So I think there is some value in having diversity. There's some things that we can learn from the dominant culture as well. But I suspect that keeping these historically Black colleges, keeping these programs that are designed to try to train minoritized people, minoritized, is an essential problem that we're going to have to continue to struggle with now that race has been removed in college and medical school admissions to the extent that it has. I think that, if we graduate people from high school, if they're focused on going to college, I think it's a good problem to have, to say that we have too many African Americans to go to our colleges. We have to think of ways of trying to get more of those high school graduates to think about four-year college afterwards. And with tuition being what it is, it becomes a much harder proposition. There was an article in the New York Times a couple of days, well, it was the Wall Street Journal a couple of days ago, about the value of a college education, now I think about it. And they were saying how a four-year college education may not be worth what it used to be. And in certain specialties, if it's a non-STEM field, for instance, you may think very carefully about doing it. Well, I hope that doesn't discourage a single minoritized person, because we need to have every minoritized person possibly educated in this country. Education has been the key to success for advancement of minoritized people in this country from its inception. And no matter what your income level is, no matter what your education level is, going to college pays more in the end than not going to college.
That is a, like you said, great question, as well as, of course, great answer for us to understand. One of the things that really touched me, though, is I went to HBCU, as you know, Xavier University in New Orleans, and then came to the University of Chicago, which is actually in a predominantly Black neighborhood if you go to the South versus you go to the North, or kind of right around there. But that being said, what it did teach me to be educated in both of those types of schools, as well as the education that I had growing up, is I was able to connect and communicate with people of all races. Being in the organization that I'm a part of now, you know, we have people from all over the world. So whether, you know, and really predominantly maybe in California, maybe Filipinos. Also, we have our LGBTQ plus colleagues as well. So I'm learning so much about how to be a better communicator for all types of people. And that's something I think we learned definitely at our HBCUs, probably the locations that I grew up in, as well as being able to travel around the world and provide healthcare. Learning from the different countries that I've been in, Puerto Rico, Guam, Japan, Jamaica, Fiji, learning from all of those people as well and bringing that back to the experience. This question is about burnout. Do you think there's a racial ethnic difference in burnout with staff whom are Black? I am currently a college grad trying to take a gap year. Hold on, let me just trying to take a gap year before applying to medical school. And sometimes I find it hard connecting with Black physicians, being expected to train students as opposed to their Black physicians, and it can be frustrating at times. I hope I asked that question so it's understandable. First of all, burnout.
Well, so let's talk about burnout. One of the things that can lead to burnout, and this has been studied by a woman named Lottie Derby, Lottedybye. She used to be at Mayo, now she's at the University of Colorado. And she's studied extensively burnout in medical students and residents and physicians. She worked with a guy named Tate Shanafeld, who's now at Stanford, but when they were both at Mayo. And what they use is what's called the Maslach inventory. It's a rating scale to determine how burned out you are. And what she did was she looked at burnout as a function of race and ethnicity. And when she looked at medical students, she followed a longitudinal group of medical students over several years. And she found that if you are a minoritized medical student, Latinx or Black, who has not experienced discrimination, your Maslach inventory score is better than a white student's Maslach inventory score. And they found that medical students had better Maslach scores going into it than age-matched people who they compared it to. And when they start medical school. Now that changes as a function of time. As you go through your years of medical school, your Maslach score goes down, your burnout increases to some extent. But minoritized students who have never been discriminated against are better, higher scoring in terms of not being burned out than their white counterparts. Now, if you're a minoritized person who's the victim of discrimination, your Maslach score is far worse than your dominant culture counterpart. And so the environment is what is really a concern for those people who suffer from the environment. So discrimination, mistreatment, harassment, abuse, scoring that is affected by racial bias, ethnic bias, gender bias. Those things can actually demoralize you to the extent that you do suffer from burnout. And then when you suffer from burnout, what she went on to show is that your work performance suffers, that you miss things that are right in front of you, that you can't focus as well, that you are always second guessing yourself in ways that make you appear to be far less confident, which you are, than your other counterparts who haven't experienced this type of discrimination, this type of mistreatment. And so now that you are burned out and your work product suffers, now if people have the ability to evaluate you without implicit bias, without explicit bias even, then they would say that your work is not as good as that of your peers, because it probably isn't, because of burnout. And with burnout comes depression, and with depression comes suicidal ideation, and it's just a gradation of steps in the lives of individuals who are the victims of bearing the brunt of mistreatment, discrimination, microaggressions, macroaggressions. And these things are far more commonly felt, as in other work that she's done, by minoritized individuals. And so, yes, there is a burden with respect to burnout that minoritized people in healthcare settings see. A paper by the chair of Indiana's surgery department, Carl Billamoria, suggested that if you are an African-American surgical resident, and they actually evaluated all the surgical residents in the country, they had a 99.3% response rate on their survey because they attached it to the in-service exam, the in-training exam that everybody in surgery has to take. And so they got a 99.3% response rate. They found that 65% of women suffer gender discrimination. 20% of women suffer sexual harassment. 16% of residents report racial discrimination. Now, if you look at African Americans as a cluster, 71% of African Americans report discrimination. 65% say that they were felt to be people who were other than physicians, even though they're wearing scrubs and white coats with a stethoscope around their neck. 56% of Black surgical residents felt that they were called somebody else of the same race on their team by somebody on their team, a major microaggression. I don't know about you, Dr. Kelly-O, but when I walk through the hall, people who I operate right next to on a regular basis don't even acknowledge me. If I don't have my scrubs on and standing in their operating room, they don't know who I am. And it's like Ralph Ellison's Invisible Man in some circumstances when you walk through a hospital. That level of microaggression is a very common phenomenon, and it makes you feel as if you're not really part of the environment. The fact is that these microaggressions are not major things, but they are things that can demoralize you on a daily basis. You never know where they come from. They're unexpected, and it keeps you hypervigilant because you never know where it's going to come from. And I think that's the thing about microaggressions, is they can keep you off balance and cause you not to ever really blend in with the group that you're there with. And it's that teamwork and that cohesiveness that's really part of delivering excellent care. So if you don't have that inclusiveness, that sense of belonging on a healthcare team, you're going to feel more at risk in terms of taking care of people sometimes. And so I think that might contribute to burnout too, because when you're unsure of yourself, you're unsure of your team around you, you may not feel that you can take care of patients in the best possible way. So it shocks me sometimes that we still deal with these sorts of things, but we see it every day. I saw a post of a young woman who was in training, who was complaining that she was called by her first name, whereas her 1 year less in training counterpart was referred to as doctor. And this is a very common phenomenon that we have in medicine, where women are devalued, where minoritized people are devalued and are called by their first names, where other people in the room are called by doctor. And people aren't even blunt about it. They'll go, "Hi, doctor, 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 doctor," and Ebony, and all around the table. And it's just incredible how this happens, and people don't even see that they do it, which is the thing about microaggressions, that people may be unaware that they're doing it. And you have to try to make people more cognizant and conscious of the ideas, intentional about what they actually do and the harm that it causes when they don't think about it. Sorry, Dr. Kelly-O.
Raven Talvo, please come off your mute and ask your question. He is an amazing healthcare executive, and I want to make sure he has time with you.
Yeah, thank you, Dr. Kelly-O, O.M.D, and Dr. McDade. So I'm Lieutenant Raven Talvo. I'm a nurse executive. So thank you for sharing insights, and addressing healthcare disparities as a global issue is a complex challenge, right? That requires a holistic approach. We need to examine every aspect of the healthcare system, from policy and payment systems to staffing models, EMR, EHR documentation, and data extraction methods. More fundamentally, it is a shift in perspective, moving from an individual-focused care to a more comprehensive approach centered on population management. So I see a lot of my feed right now on LinkedIn that there's a lot of initiatives or happening, right, to tackle healthcare disparities. But I feel like, with the chat GPT and AI, I feel like this is going to be kind of the sustainability in healthcare, right? It's going to be pushed to the side. So how can we ensure that we not only keep this conversation alive, but also make a real impact in our efforts to improve healthcare equity?
Well, that's such a huge point that you raise. I mean, the idea that artificial intelligence has now invaded healthcare is exactly what you would expect, and you would think that it would be for the good. And you remember the Watson commercials from a few years ago when Watson was in an M&M in a cancer center, and all the cancer papers were fed into Watson, who then synthesized them for you and then came up with the correct solution to what treatment would be optimal for this particular patient. I mean, that's our dream for AI, that somehow or another, using all the data in the world that's available to it, real world data, that you can actually see which combination of drugs or which sequence of events is the best in order to care for somebody. And ideally, that's correct. But you have to look in terms of how it impacts minoritized communities. Minoritized healthcare outcomes are already poor. So if we're using real world data to fuel the algorithms, to feed the machine learning that trains the AI algorithm how to improve care, we're training it with data that's already disparate with respect to outcomes. And so if we feed in disparities into the model that the algorithms use, then the algorithms will only produce those same disparities in the end. We have to do something radically different in terms of programming those algorithms to try to adjust for the fact that we're putting in data from a system that was built on health disparities before we can actually turn to those AI tools and say they're going to work for everybody. And that's what the real solution is, or the real problem is, in using AI without thinking about what data is being taken in by that AI algorithm. It's like, for instance, if you had an algorithm that's able to detect a certain phenomenon of a low frequency in a really large background, and then you focus in on that low frequency population and then try to extrapolate that low frequency solution to that large population, it won't work. Well, it works the other way around. If you look at the large population and try to then apply that to that small population, then it won't be effective for that population as well. So I think that we have to be very cautious about the AI tools. I look at the AI tools in terms of workforce. There's the idea that there's a group that helps you just go through your residency applications very quickly. And it uses AI to help you to select the type of resident that you want and the number of residents that you want, and rank them in the order that you want, without you having to go through the applications by hand yourself. It's kind of a fool's paradise to think that somehow is going to give you a better resident. I think that you have to insert brain and take some time and deal with relationships and people and how they interact with your patients and your community, that I don't think an AI algorithm can do right now. But the fact is that people are looking for these shortcuts because medicine is becoming a lot more competitive than it used to be, especially in certain fields. I'm an anesthesiologist. Anesthesiology used to be walk up and become an anesthesiology back when you started your training, Dr. Elmore. But the fact is that now it's a very competitive field. And so now, you've got people all over the world who want to be trained in anesthesiology in the United States. And so the programs can select from the very best residents and resident applicants. Well, they get, 2,000, 3,000 applications for a program that has 17 slots. And so how do you decide which people you're going to interview, and how do you decide from those people who you're interviewed who you're going to rank? If you had an AI program that could tell you how to do it, that's really the panacea for every program director in the country. Well, what happens is everybody ends up selecting the same residents. And then when you go to that next group of residents, you've now lost some of the touch of who they are as people potentially, and they may not be a good fit for your program ultimately. So if you're trying to play things by the numbers or by an algorithm, I think you sometimes have to say you have to insert a brain, insert a heart in order to get the best people there. And you have to look at where people come from before you train them. I think if you want to train more rural physicians, there's a great shortage of rural physicians now. You should train somebody who grew up in a rural environment. If you want to train somebody, if you want somebody to go back and practice in the inner city, you have to train somebody who came from the inner city to want to go back and practice in an environment like that. And I think that's one of the things that gets underplayed in these algorithms, that place and space are important with respect to who's going to serve that particular community. If I even ask first-year medical students, as the AAMC, the Association of American Medical Colleges, does every year, whether you intend to see a disadvantaged or minoritized population, underserved population after you graduate, 64% of African Americans say that's what they're going to do. About 60% of indigenous physicians say that's what they're going to do. About 50% of Latinx physicians say that's what they're going to do. White and Asian students in their very first year, 22, 23%. We have 4 years of a medical school curriculum to persuade them that serving the underserved is a good thing as a physician. The data don't change in the graduating student questionnaire as senior medical students. You know who's going to be in that underserved group when you admit them to medical school. And that's why admitting a more diverse class with more of those indigenous, the African-American, Latinx physicians, medical students, is so important in terms of trying to provide access to care in underserved communities.
Such a great question. Thank you, Mr. Talvo, for that great question. Thank you, Dr. McDade, for all of the answers that you've given us. Like I said, Dr. McDade is going to be back because there's so much more to talk about, and we need to delve into this. I will add the last thing. What we need to do is exactly what we do here on Ask Dr. Kelly OMD, exactly what we do in the Viva Life Health Hub. We bring people together that really are concerned about closing the gap in healthcare disparities for whatever minoritized group that we're talking about. So I want to thank each one of you for signing up for this program, as well as you are on our contact list. So we want you to come back because we are constantly bringing back subject matter experts, gurus, amazing people that have given service to the communities that we're talking about. And we're so grateful for them. All right, y'all, that's the end of Ask Dr. Kelly OMD. You can find us at vivalifehealthhub.com, drkellyomd.com, on Instagram, as well as Facebook under Viva Life Health Hub and at Dr. Kelly OMD. This is a passion, this is a purpose, and it is a divine plan that we will continue to do each and every Monday night as long as we possibly can. Have a wonderful evening, and don't forget to do what? Viva Life. All right. Thank you for being a part of the Viva Life experience. I'm Dr. Kelly O.M.D., board certified OBGYN and healthcare executive. If you like what you heard, then please go ahead and like, share, and subscribe. The reason why is because we are trying to educate, encourage, and inspire 1 million people to live their healthiest and wealthiest life. And this is what we're bringing you. We're bringing you educational videos. We're bringing you podcasts. We are bringing you webinars with subject matter experts, including myself, about the topics that affect you the most. So go ahead, like, subscribe, and share. We are everywhere. Have a wonderful day. Viva Life.